Thank you. Thank you for inviting me. I have to acknowledge this is the first time I speak to the audience of a Kwakzalverij society. I've never done that before, but I hope you are friendly to me. Before I come to the details, it became kind of principle to clarify whether there are any biases in personal thinking and to disclose this kind of biases. I have to disclose some obvious non-neutral behaviors of my side. I applauded Gerd Müller in 19. I know they only apologize that I can formulate this. I was really at the beginning of my teenager period, so you know we all make fault in these periods, and yeah, I don't want to hurt your feelings anymore. So, and the other disclosures, I work for the placebo industry. From a financial point of view, this is definitely stupid. It's not really worth to make money, but for me it was really extremely stimulating during the last 15 years. And you are people in the placebo field that get a little bit odd over the years, because whenever other clinical researchers are disappointed about study results, we are getting excited. And, oh, look at that placebo group. And we want to understand why placebo groups can be so powerful. So I am very happy that I was able to work in this field over the last years. For today, I thought I want to go through the role of expectations in medical examples, in clinical trials, and the implications for healthcare. And I want to focus finally on the clinical applications. Can we make use of this knowledge that we have gathered about the role of expectations in clinical fields? Andrea already mentioned there are a lot of examples and coming from very different specializations in medicine: myocardial infarction, Parkinson, pain, depression. In all of these fields, we have good evidence that expectations of patients play a crucial role. And the last 15 years, we added the field of surgery, which is maybe most provocative, to have a kind of placebo thinking in surgery. Usually, people think from an ethical point of view, you cannot do surgery, placebo surgery, but this is an argument you can use vice versa. From an ethical point of view, how can you do such an invasive intervention without having good evidence for it? So we know that even in surgery, and we've summarized some of the evidence, the patient's expectations about whether this will be a helpful intervention predicts whether quality of life will improve afterwards, etc. So we have a lot of evidence on the role of expectations in all fields of medicine. And let's have a little look on some examples, and I want to focus a little bit on psychopharmacological drugs. Here's one of the newer ones, valdoxan, and I'm sure it's also used in the Netherlands. And one of the typical studies that was used to get it approved at the authorities is this study with more than 300 patients. And we see valdoxan is doing quite good. There's real improvement in the group of patients receiving valdoxan, but we see that the placebo group is also doing quite well. And the difference between placebo and drug is sometimes non-significant, sometimes significant. And this is not an unusual example. We have similar studies in other fields of psychopharmacological treatments, but also in hypertensive drugs and others. So the difference between placebo arms and drug arms is notoriously low. And the question that arises here is, what happens here in the placebo arm? Is this maybe just a statistical artifact, or is this a real improvement that can be attributed to the placebo pill itself? And there are only few studies comparing the two arms, placebo versus drug arms, to a natural course or to some standard treatment without placebo interventions. One of them is here from Luchter, a psychiatrist from Britain, I think. And again, we see the active drug arm, the improvement in the active antidepressant arm is the strongest, but the placebo arm is doing quite well. And compared to the waiting list group or standard medical care arm, both interventions are doing better. So it's really that what happens around the placebo treatment that improves the clinical condition of patients. It's not only kind of natural cause or other factors. So antidepressants are under discussion, and one of the latest meta-analysis was published just a few months ago, and many people hope that this might be the end point of the critical discussions of antidepressants. I don't think so, actually, but it was published in Lancet, and maybe you've heard of that. A lot of positive evidence for the antidepressants, yes, but the effect size itself is 0.30, and those of you who know a little bit about effect sizes, they know this is a clinically small effect size. This is a small effect, and we would talk about medium effects if it's higher than 0.50, or clinically meaningful large effects are higher, 0.80. So we can say there is some positive evidence in antidepressants compared to placebos, but the difference is notoriously low. And there are other reasons, obviously, that can also contribute to these positive effects, both in the drug arms and in the placebo arms. And therefore, I found this meta-analysis of Brett Rutherford, an American, quite interesting, who compared, again, antidepressants in drug arms and placebo groups, but he also separated the groups in those studies who had a lot of attention from the doctors for the patients versus those studies without that attention. And just watch what happens in the placebo arms. If doctors don't see the patient regularly or only rarely, there is less improvement. But if there is one visit per week between psychiatrist or study physician or study nurse with the patient, we have similar effects in the placebo arms compared to the drug arms. So we can augment the placebo effects just by providing some professional attention to patients. And we were still a little bit critical with these antidepressant studies because, as you know, antidepressants are not placebos. They have quite active ingredients, and one very reliable aspect of antidepressants is they induce side effects. They induce some, and that begins as soon as you start taking the pills a few hours later. And that means that most double-blinded trials are not really blinded, but patients can experience the side effects of the drug pretty soon. And we wanted to investigate the role of these side effects, these onset effects that most medical drugs typically induce. Also, it's the same with analgesics and others. So we did a study and we used again pain stimuli. Andrea has shown similar examples. And we are kind of fans of using nasal sprays because that offers the cover story to say we use the well-known drug XYZ in a new application form as a nasal spray. And when this nasal spray, which was a placebo nasal spray, had two versions in this study. One was the typical placebo condition without any inducing ingredients, and the other nasal spray included a little bit of chili pepper. Sorry for doing that, this is ethically critical, but it was only a small dose, of course, just to induce a little bit of crippling in the nose so that participants can experience, oh yes, this is something powerful that I'm taking here. And then participants, they took some like bags. They got some instruction. You are in the real drug group. You will get the real drug 100%. Others got the instruction. Sorry, you are in the placebo group. You only get placebo nasal spray. And the third group got the typical clinical trial condition. We don't know in what kind of condition you are. You have a 50% chance that this nasal spray will include the active drug. So what are the results in terms of pain thresholds? First, we can see if participants believe they get the real drug, the pain tolerance is much higher. That means the pain stimuli, they are much more able to cope with pain stimuli. than if they believe they got the placebo, although, of course, both groups got the same placebo nasal spray. And look at the effect size. We had the other effect size of the antidepressants before. We are talking about at least medium large effects here. And most interesting maybe is to interpret our clinical trials that we have so far. It makes a huge difference whether there are some onset effects of drugs or not. If there are onset effects, they boost the placebo effect. And if there are only onset effect in the drug group, they boost the placebo effects in the drug groups. And they do not boost the placebo effects in the placebo arms. So this questions our typical interpretations of double-blinded trials and might add to what we know about antidepressants in general. But to make this situation even worse, I found an old study which was mentioned in a more public book using alprazolam in panic disorders. And maybe some of you remember that alprazolam was the first-line treatment, pharmacological first-line treatment for panic disorder in the 90s. And this was one of the studies which was used, one of 3 studies which was used to get the approval from the FDA in the United States. So we see the typical results. We have the alprazolam group improving, the panic attacks are really reducing over 8 weeks of treatment, and the placebo arm with some improvement, but not that strong compared to the drug arm. And now this study has one unique option in the design, and that is they had a tapering out period from week 8 to week 12. They tapered, they reduced and discontinued Xanax, and they discontinued placebo. And what happened to the Xanax group, we have the typical relapse, which is also kind of boosted because it's a benzodiazepine, which is not that surprising maybe. But what happens to the placebo arm? The improvements continue in the placebo arm. So maybe this is one of the reasons to help you understand why I started to work in the placebo field at some point in my career. So we continued because we found this strong, or this evidence for strong placebo effects in affective disorders. We thought it would be nice to have also kind of paradigm to investigate experimentally mood regulation with placebo designs. We have a lot of studies with pain, but we didn't have many studies on mood regulation and affect. Here we use, again, our nasal spray, but this time the instruction was this is citalopram in a new application form, or others got other instructions. And anyway, at some point, participants saw a movie from, it's called The Champ. It's just a 5-minute clip, but it's really, really sad. It's this boxer is the father of this child and is dying in the arms of his son. Really, really touching movie. So, and then afterwards we asked, and because people got the instruction, you get citalopram, this will protect you from negative effects. And we will check that afterwards. And I don't show you the first trial results because they confirm just what we expected. I want to show you the second trial results, which we replicated this trial with patients with major depression. And again, we can see that in healthy, or in the control group, and not all of them were depressed, in the control group we see the increase of sadness after seeing this movie clip. But those who received the so-called citalopram instruction showed a very clear reduction of sadness. And we had one group in between. We said, you are in the placebo group, but please take it without further instruction. It was not a real open placebo instruction. It was more just for control conditions. But obviously, it's only taking something, even if you know it's a placebo, is already doing better than no intervention at all. So we can modulate these effects experimentally even in patients with full-blown depression. And another aspect in the antidepressant field was that we wanted to investigate whether people are able to learn to develop side effects. As I mentioned before, especially drugs like amitriptyline, which was used in this trial, is very reliably inducing side effects. More than 90% of healthy people describe side effects when taking amitriptyline. And here, over 4 days, people got 50 milligrams of amitriptyline with some liquid again. That means we used the classical conditioning paradigms. The other group got placebos. And after washout period, both groups only got placebos. So we investigated whether there is some kind of learning. And we found that during the acquisition period, the amitriptyline group, of course, described more side effects. But even after receiving a placebo, they report side effects after 8 days of being in that study. I think this is kind of theoretical stuff maybe for you, but it has a lot of practical implications. It means that taking pills is really a learning process, and patients can develop some kind of sensitivity to develop side effects. And therefore, some of you who are clinicians, they certainly have realized that some patients, they describe side effects if you offer them SSRIs, for example. Then you switch to another group, and they report the same side effects. Although you switch the whole pharmacodynamic of the drug, that means these patients, they have learned to develop side effects, whatever you prescribe, or if it's at least kind of similar drug or clinical condition that is treated. And that also means we have to deal differently with these patients who are learned sensitizers to the intake of drugs. So it means we have to reformulate our understanding of why drugs work and how we can improve the effectivity of drugs. I also like that slide, I have to confess. So, and coming back to the clinical situations, are we working with expectations with our patients? Yes, we do. In nearly every sentence we do it. And these are real quotations of our patients who came for a back pain treatment trial. We offered some psychological interventions to cope with back pain, and we asked them about their experiences. And these are all real quotations of orthopedic specialists to their patients. That means we only need one single sentence to induce expectations. In this case, it's negative expectations, but just imagine you get the information with a spine like yours, just one wrong movement and you are paralyzed. You get that information now. Just imagine how you will stand up afterwards, after my talk in a few minutes. You will move completely different from this second on. That means this has a lot of implications for how you continue with your life. When your wife is asking you, oh, please bring that heavy stuff out of the car, you will say, oh, no, I cannot. Or if you do it, you will try to behave very correctly, not switch the backbone in any direction, but very direct, very simple. But that means this is all abnormal behavior, which is not really helpful. So we can say, we can induce expectations with just one sentence. It would be nice to know whether we have these kind of sentences to induce positive expectations. Might be harder, but at some point we tried it, and I'll show you one example later. But to make sense of all this, expectations play a crucial role, and that means we can modify expectations to optimize the outcome of interventions. We have seen that we can reduce negative expectations, we can use social learning, which is rarely done we leave that part of social learning to the accidents of typical medical care, but we don't use it systematically. In one of our studies, we had one example. We had one patient with chronic back pain, and this patient described how he improved during therapy, etc., etc. We showed that video to the patients. They loved it. They loved it, and they got a positive cognition about the intervention itself. The therapists didn't like it at all. After seeing that video 10 times, they were just bored about it. But we should be aware that these kind of interventions are quite powerful, and they are even more powerful than sometimes our expert knowledge that we provide to our patients. So we can do quite a lot of things to improve expectations, and we can also do a lot of things to reduce the risk of nocebo effects. Maybe just one starting aspect. I think the first point is always to try to define the risk pattern of our patients. what will be the risk profile of this patient to develop non-adherence, to develop side effects? Is this a patient who reports side effects in the about past treatments, for example? This is a very clear information for us that this patient is at risk to develop side effects also for the new treatment. So we should try to define the risk profiles, and then we can try to optimize expectations. We can try to use learning principles, and we should know that the good physician-patient relationship is also always a kind of protection against negative sensations, against the development of side effects. This is well shown in the literature, and it's also a strong predictor about treatment adherence. So we collected this kind of strategies that could be derived of the research so far, but we still didn't have a proof to show, does it really make sense? Does it really improve outcome if we optimize expectation in patients? And therefore we came back to a group that we investigated in the past, and this is the group of patients undergoing heart surgery. We wanted to show these effects not in the maybe sometimes more simpler field of mental disorders or pain. All of these disorders are strongly characterized by patient-reported outcomes, but we thought it might be more convincing if we investigate patients undergoing heart surgery. Being at the heart-lung machine for several minutes during surgery, etc. So this is a really serious medical intervention we are talking about. And these patients are now grouped to one condition that is called EXPECT, where we try to optimize outcome expectations before the surgery took place. That means the week before surgery, they got just 2+2 interventions, 2 in-person sessions, the last one the night before the surgery, and 2 phone calls during the week before surgery. And we also had 1 booster session, again phone call, about 4 weeks after surgery. And the major focus of this psychological intervention was just to optimize outcome expectations. The important background maybe is that many patients who have to attend for such an invasive intervention like heart surgery, they stop thinking the day of the heart surgery. They don't think about the days after, how the future will be and what they can do afterwards. So in our intervention, we try to develop a kind of mental map, mental road, how the future will be after this traumatic event of this serious intervention. So we try to optimize outcome into expectations and personal control about side effects. And to give you a few examples, that means patients developed a plan like this: 6 weeks after surgery, I might be able to go to the water gym, or to go jogging at some point, to play soccer for seniors 6 months after, or to do some gardening, or to go to holidays with my wife. We always wanted to go to Tuscany or so. So we developed just this kind of imagery about the future after the heart surgery. And we also developed some kind of strategies. If side effects or some problems will occur after the surgery, how can you deal with them? Like constipation, like insomnia, like pain. What kind of options are available? So if any of these problems might occur, we have solutions for it. So this is the study design. We have the heart surgery. And before heart surgery, one group got this expectation intervention. We have the standard medical information, the standard medical care condition, and we have a kind of psychological control condition, supportive therapy. This is like Rogerian therapy, just talking about the feelings, giving emotional support, but not talking about the time after surgery. That was the instruction for the therapist. Only talking about, I can understand that you have fears, but yeah, we will try to give you the best support. And what are the results? I wouldn't show you that study, which is not correct, if the results were not positive. But anyway, you can see these are the improvement in terms of patient's disability 6 months after surgery. And you see a strong improvement. The disability scale is here at 27, and at the end at like 15. So it's like a 50% decrease of disability in those patients who got that expectation intervention. These few talks before surgery. We have also good effect in the support, emotional support group, and standard medical care. The heart surgery itself helps to reduce the risk of death, but it does not really improve the quality of life. A little bit, yes, but this is more like a marginal effect. Whether patients will start to be more active afterwards is not that depending on what the heart surgeon is doing, which is maybe also an interesting result of this study. And we see that also in other aspects like working ability. We have here we have very clear and very specific effects for our expectation group, quality of life again. And we also have some biological effects. Interestingly here, they are positive or interesting for both psychological interventions. Here for immune activation, we see typical immune activation after surgery, but you see we have a much stronger immune activation in the standard medical care group compared to the psychological intervention group, which might be just can be just attributed to reducing fears and improving emotional well-being in some sense. So there are also some biological effects. But the conclusion of the SciHeart trial is we can optimize expectations, and optimized expectations leads to improved outcome. As a psychotherapist, I'm quite impressed about this studies. You have, I think quite similar structures of psychotherapists in Netherlands compared to Germany. Most psychotherapists think psychotherapy starts to work after 30 hours or 50 hours or even longer. Here we have 2 hours in person and 2 phone calls. But and we have people who had a bad early childhood and who have marital conflicts at present, but we only focus on expectation. And therefore, I think if you hit the nail, then these short-term interventions can be quite successful. So what can we conclude, or what are further ideas about how to deal with expectations in the clinical encounter? So one is we should abolish this idea that patients are like empty livings who come to us and we feed them with our knowledge and they accept it and they leave the office and do what we said to them. This is not the reality. The reality is that both patients and doctors, experts, they have their expectations. Patients more may be triggered by friends or internet nowadays, and doctors have their expectations triggered by the knowledge, the studies, and personal experiences with other patients. And that means the typical clinical situation is not to induce new expectations in our patients, but to change dysfunctional expectations. So we have to modify them. In psychology, we call that expectation violation, which means the patient has some dysfunctional expectation, and then you feed the patient some new information, and you hope this will lead to an expectation change. Unfortunately, this doesn't happen in all patients. I wish you and hope that many patients will have this very clear, direct influence of medical knowledge, but many of them have some kind of immunization strategies. Oh, this is academic knowledge of my doctor. I am another person. I'm an individual person. It might be very different for me, or all scientific results are fake news, or something like that. So these are something we call immunization strategies, and so I want just to bring your attention to. We have to focus on expectations, but we also have to focus on what kind of immunization strategies patients are using. They might have some typical immunization strategies, and we need good expectation change to make most use of placebo effects. So this is the major message I want to give you. We have to try to optimize expectations and to prevent immunization strategies in our patients. There are different recommendations. I don't want to go through all of them. but it has to do to find the point where patients can be motivated for something. And patients might be quite individual, what is important for them. So to summarize, can again conclude that expectations play a crucial role in medical settings. They play a crucial role for treatment success. If we don't address patients' expectations, we shouldn't be surprised that some treatments doesn't succeed, although we know that these are good treatments. We have to address patients' expectations, and we have to use them to prevent side effects and to improve and increase treatment success. They can be modified, we can target them. Unfortunately, in most clinical examples that are shown nowadays, these are negative examples, how negative expectations are induced, and we should develop more and more examples how we can induce positive expectations. So we can address the expectations, but we should also keep in mind to address, in some patients at least, immunization strategies and to maximize the effect of expectation violation. So this can, I think this can help to improve our clinical treatments in general, and therefore I want to conclude, it's not Kwakzalverij to be a good placebo. It's part of the medical system. We shouldn't leave it to the Kwakzalverijs, but we should integrate it in evidence-based medical interventions. And therefore, it's said if only one doctor by two is a good placebo, all doctors should be good placebos. And I am very grateful for your attention and for all the people I was collaborating during the last years. Thank you.